Good evening, everyone. Happy New Year. Thank you for making time for this webinar. This is our first for the year 2025, and it's good to have you on board. I think we'll allow a minute for just a few more colleagues to join in, and then we roll it from there. But just get yourself comfortable. We're looking forward to an interesting conversation with Dr. Joseph Nyamiobo as our presenter. The numbers are encouraging and overwhelming, and that is a good thing. Tell a friend to tell a friend. Those who haven't yet joined, I've put the reminder in the groups, but still, or you can share in other groups as well. Let's give it a minute, maybe 50 seconds now. All right. Good evening once again. For those who've just joined in, Happy New Year 2025. Welcome to our first webinar. Hopefully there will be a series every month, but here we are, and we are privileged to have you on board as Kenya Psychiatric Association. My name is Dr. Rajab Saddam, CME coordinator, and it's a privilege to have you here. I would like to recognize the presence of our president, Dr. Mercy Karanja. And before we actually start the webinar, I would like to take this opportunity to just welcome her, given that this is our first actually meeting for the year as the team of mental health practitioners, both psychiatrists and allied colleagues. She makes a few remarks and then we get into the business of the day. Karibu sana, Madam President.
Thank you very much, Dr. Rajab, for that introduction, and good evening, colleagues, and Happy New Year. It's indeed another year that we are really glad to and grateful to have with us so that we can make a change in mental health. And I'm actually very delighted that this year we have actually started on a very good note. We're remembering the events of last week with the High Court ruling, which was a landmark victory for KPA and Kenya as a whole, when the High Court declared that the Section 226 of the Penal Code is unconstitutional. And this was efforts driven by the Kenya Psychiatric Association, the Kenya National Human Rights Commission, and the late Charity Muturi, and other key partners who made this possible. So we are really starting on a high note, and we shall continue to ensure that we have more collaborations to enhance mental health in our country. And as I stated in our New Year remarks, that we are very invested to partner and collaborate with all stakeholders, even across the borders, so that we can ensure that we enhance mental health policies and mental health practice. We are heavily invested this year in the professional development of our colleagues, members, and we are grateful to our partners for the support they have been according to us. We aspire to be even a more vibrant and dynamic association with more expansion in our professional development opportunities. And I'm sure with the capability that we are already seeing in the NEC and in the guidance we are getting from our very able CME coordinators, we have a lot of things lined up this year in terms of professional development, including creating more awareness and advocacy on what is the outcome of this ruling that was pronounced by the High Court. So members and colleagues and partners, I want to welcome you to this CME and also mention that we have a lot lined up this year and we are seeking your support and collaboration so that we can advocate for better mental health policies, increase awareness, expand mental health literacy, and even develop ourselves professionally by sharing the best practices scientific research and knowledge for the betterment of mental health care in Kenya and beyond. So asanteni sana colleagues, and Dr. Nyamiobo, thank you very much for accepting to lead this discussion this evening, and also to our partners for supporting us. Thank you very much, and over to you, Dr. Saddam.
Thank you very much, Madam President, for those brief but very heavy remarks. I'm sure it's going to be an eventful, okay, when you say that, it's an eventful, not an uneventful, but an eventful year. We hope that actually the things we've deliberated to execute this year will be able to meet majority, if not all of them, and all for the benefit of the community. For the business of this evening, we are tasked to do a presentation on management of Parkinson's disease and the extrapyramidal side effects. And our presenter is my good friend, Dr. Joseph Nyamiobo. Dr. Nyamiobo is a distinguished psychiatrist with a Master of Medicine in Psychiatry from the University of Nairobi. He's a passionate advocate, particularly dedicated to advancing men's and adolescent mental health care. His approach combines clinical expertise with wellness promotion, aimed to reduce stigma and promote open conversations around mental wellness. Currently, Dr. Nyamiobo serves as a corporate psychiatrist at Chiromo Hospital Group, where he not only provides comprehensive care for patients, but also plays a key role in staff training and clinical quality assurance, ensuring the highest standards of care. Outside of the profession, of professional commitments, Dr. Nyamiobo is a strong proponent of physical fitness as an essential pillar of mental health. He does a lot of marathons and walks, and gives some of us a challenge on that. Karibu sana, Dr. Joseph, the floor is yours. For those of us with questions, please put them in the Q&A chat box, and we'll get to them when we get to them. Karibuni sana. Dr. Joseph, the floor is yours. Karibu.
Thank you very much, Dr. Rajab. Thank you very much, Madam President. And thank you very much, KPA and esteemed colleagues, and everyone involved in this CME presentation today. As Dr. Rajab has put a lot of rosy words, that is myself, Dr. Nyamiobo Joseph. I'm very honored to present on this day, a day before my birthday. And I hope I will be learning as much as yourselves. I have no prior experience in Parkinson's more than anyone else. So this is also a learning experience for myself as it is for you. So today we are going to talk about how to manage Parkinson's disease and the extrapyramidal symptoms. And we will start by probably discussing how we get these patients in our clinical setups. So the first case is the case of a 53-year-old male who had been on follow-up by a neurologist for Parkinson's disease after presenting with a history of muscle rigidity, tremors, shuffling gait, and episodes of falling and confusion. He had been he had had these symptoms for 3 years, but kept on seeking second opinions. But 1 year prior to presentation, he started on treatment, that is carbidopa-L-dopa. And after a year of being on medication and on follow-up by the neurologist, he presented to us with allegations from the family of progressive restlessness, forgetfulness, irritability, insomnia, and visual hallucinations, where he would say that he would see demons chasing him and wanting to harm him. And he would also have very vivid dreams of people beating him up when he was asleep. So the second case is the case of a 37-year-old male who had been on treatment for schizophrenia after having this first episode 3 years prior to presentation, and a second episode 2 years prior to presentation of clear psychotic symptoms. He had been on antipsychotics, and of note, they were second-generation antipsychotics. And 1 year prior to presenting to us, he presented with he had started experiencing tongue rolling and restless legs. And 4 months prior to presentation, he started, the relative started noticing that his eyes would bulge. At that time, the antipsychotic frequency was changed from monthly to every 7 weeks. In short, the dose was reduced. And as you're going to learn, this temporarily worsened his symptoms, and that is why he presented to us. And at that time, he had also been on vitamin E. So Parkinson's disease and Parkinsonian-like syndromes actually were described in ancient Egyptian and Indian texts from as early as the 12th century BC. But it was named after a physician, a surgeon, and a pharmacist, and also a political activist called James Parkinson, who in 1817 wrote an article called An Essay in the Shaking Palsy. And in that essay, he described it as involuntary tremulous muscular power, in parts not in action, and even supported with propensity to bend the trunk forward and to pass from a walking to a running pace. At that time, he also noted that the senses and intellect were uninjured. So to him, he noted primarily a motor problem. So when you think about statistics regarding Parkinson's, the prevalence is around 1 to 2 per 1,000, which is a big number, with less than 1% of the cases presenting at before 30 years old. And as people grow older, the prevalence increases to 1 per 100 by 65 years. Males and females are affected equally, and it's easy of note is that prevalence of depressive symptoms and depressive illness is high in these patients, up to 63%. There is also noted progressive cognitive impairment in these patients, unlike how Dr. James had noted previously when he came up with this concept. There's also noted to be delusions and visual hallucinations as seen in our patient in up to 20%, but the older they grow, the higher the occurrences. So essentially, it is a problem with the reduction in dopaminergic levels in the basal ganglia, either by presence of what we call, when we talk about the primary Parkinson's disease, there's usually noted presence of what is called Lewy bodies, which are intracytoplasmic inclusions in the pigment dopaminergic neutrons of the substantia nigra. This disease becomes clinically detectable when approximately 70% reduction in the dopamine levels occurs. So there are a couple of known causes, and some of them are neurodegenerative, which include things like ALS, central myelinosis, corticobasal degeneration, diffuse Lewy body disease, dopa-responsive dystonia, familial olivopontocerebellar atrophies, some dementia complexes, and also idiopathic basal cell calcifications. There are also juvenile Huntington's disease, Pick's disease, rigid Huntington's disease, progressive supranuclear palsy, multiple system atrophy, and Wilson's disease. So generally, all these have shown some problematic changes in the substantia nigra, especially on the dopamine neutrons of that area. Also, if there is evidence of injury by toxins to the same areas of the brain by either manganese cyanide, carbon monoxide, carbon disulfide, carbon tetrachloride, ethyl alcohol, MPTP, and neuroleptics, this may present with the Parkinsonian-like symptoms. There's also infectious causes such as JCD, HIV, and viral encephalopathy. There might also be some medical illnesses that may present with Parkinsonian-like symptoms, especially when those brain areas are affected in the substantia nigra, such as hypothyroidism, hypoparathyroidism, presence of neoplasms in the same brain areas, normal pressure hydrocephalus affecting the substantia nigra, and also vascular injury, especially if you're able to see infarcts on those areas. So what we primarily call Parkinson's disease is usually the idiopathic Parkinsonism, which if you are able to investigate and rule out all these secondary causes, such as toxins, infections, and medical issues, you label it as a primary Parkinson's disease or a juvenile Parkinson's disease. So as Dr. James had initially talked about it, there are usually motor manifestations and non-motor manifestations. There are usually three classical motor manifestations, which include bradykinesia, which is usually a globally decreased motor activity, which is manifested by slowness and decreased spontaneity. So you'll notice like they are almost like what you would say robotic. The patients would also have tremors, which most of the times are rhythmic, relatively slow, and are worsened by stress, and affect the limbs, the head, the lips, and the tongue. They also present with rigidity, which may be either continuous, or people call lead pipe, or ratchet-like, which people might call cogwheel, like how a cogwheel might move. And this is usually when there is passive movement. So bradykinesia and rigidity may result in dribbling, shuffling steps, and bent posture, and a decreased arm swing, almost like someone walking to a point of walking towards running as if they're chasing their center of gravity. So the non-motor manifestations will include a depressed mood. As we said, the depressive symptoms may be present all up to above 65% of patients. There may be presence of psychotic symptoms, as we have seen in later stages, such as paranoia and also visual hallucinations commonly. And these patients may also present with very vivid dreams. So when you are trying to treat Parkinson's disease, essentially diagnosis of Parkinson's disease is a clinical diagnosis, unless you are in an academic setup and trying to demonstrate Lewy bodies. When you're trying to treat, first and foremost, it is split into three, where there is protective, symptomatic, and restorative treatment. When you talk about protective, these are what your therapy that aims to prevent the presentation of these symptoms, or slow down this presentation if there is evidence of presentation happening. So such therapy may include from studies, things like physical activity. Some studies have controversially placed a role of the presence of smoking and smoking nicotine and also caffeine use as a protective. Though this might not necessarily be causative, it might be relational, meaning that people who have been noted towards addictive behavior may end up having genetic protection from Parkinsonian-like symptoms. So not necessarily causative. There is also a role of symptomatic treatment, which usually is using strategies that may enhance dopaminergic transmission by increasing dopamine synthesis. So such as the use of levodopa, carbidopa, like in our first patient. Anticholinergic therapy also may be helpful to alleviate the effects of the dopaminergic imbalance. And also we might need to now treat the comorbid issues that may present, such as psychosis, agitation, depression, or also there's the risk of psychosis related to dopaminergic replacement therapy. So meaning that these patients who are on dopamine replacement therapy, we already have a double-edged sword where the dopamine replacement therapy is helping the Parkinsonian symptoms, but also increases the presence and the risk of psychotic symptoms. So we will move to the next part of our presentation, where we discuss the adverse effects of antipsychotic drugs. So these two are almost similar due to their pathophysiological manifestations and their symptomatology. But so here, mostly the blockade of dopamine receptors in the basal ganglia is what presents motor side effects to our common psychotropic medication that we use for our patients. They have been rarely seen in patients who are treated with newer and typical antipsychotics due to their propensity towards D2, unlike D1, and also serotonin receptors. However, this does not rule out the presence of these extrapyramidal side effects with the use of atypical antipsychotics. You will remember on the second presentation, the 37-year-old gentleman was on atypical antipsychotics, but still presented with extrapyramidal side effects. It may be seen when higher doses are used compared to lower doses. And there are usually four main types. And we'll start with the commonest of them all, which is acute dystonia. Acute dystonia is one of the acute reversible forms of extrapyramidal side effects, which may present with what people may know as oculogyric crisis, where the patient may present with ocular symptoms, where there's difficulty in their blinking movements, and also they present with a lot of blurring vision. There's also torticollis, where patients will present with dystonia of the neck, and they have what look like a torticollis posture, almost like meningismus. There's also tongue protrusion, or people may also complain of a heavy tongue or drooling due to the inability to swallow, and also facial grimacing. There's also pseudo-Parkinsonism, which may now present as a muscular rigidity, and a patient may complain that they feel like they are robotic in their walk or in their movement, or a relative may complain that. Also, they may have resting tremors. So in this acute dystonic symptoms and pseudo-Parkinsonism, the treatment is first to reduce the dose of the antipsychotic in use, and also probably consider change of the atypical to an atypical antipsychotic if the patient is on a typical antipsychotic. Anticholinergic medications such as procyclidine and benzhexol have been shown to be helpful. We are advised not to regularly prescribe antipsychotics with these anticholinergics in the absence of extrapyramidal side effects due to potential for abuse, and this may also retard the antipsychotic effects. But of note, if a patient is antipsychotic naive, it's a good idea to psychoeducate them so that they might know the possibility of occurrence of these symptoms, because some of these extrapyramidal side effects may look very dangerous to the patient or the relatives when they start experiencing them, especially at home. There's also a role for dopamine agonists such as bromocriptine, though it's rarely used due to the theoretical danger of risk of aggravation of psychotic symptoms. As you may know, whenever dopamine agonists are used, there's the risk of reemergence of hallucinations or delusions. We also have akathisia, which is a highly unpleasant physical and psychological restlessness. There's usually a subjective and an objective component, where in the subjective component, the patient may say that they have a feeling of inner restlessness with the drive to continuously engage in motor activity, especially of the lower limbs of the trunk. But the objective component is where someone might objectively see a patient pacing constantly and unable to stand or sit or lie. So they would typically tell you that when they sit, they feel like standing. When they stand, they feel like walking. When they walk, they feel like sleeping, and they are not calm enough, and it is usually very distressing. This distress may dominate in absence of any prominent motor phenomena. And of note is that it's very reversible, and it's managed by reduction of the dose and use of anticholinergics, which are very effective. For some people, especially those who might also have acute dystonic reactions to the point that they are unable to swallow in the absence of parenteral anticholinergics, there is role of using parenteral benzodiazepines, or also you can try use of beta blockers. Then now we can talk about the late onset antipsychotic side effects, which is the neuroleptic induced tardive dyskinesia. This usually is a late onset, which means main presentation is within 7 years, but it may present earlier, even up to 3 years earlier, such as in our patient. And it is usually described as involuntary, repetitive, purposeless movements. And usually, as we have said, it's due to long-term antipsychotic use. But also of note is that up to 10% of untreated patients of schizophrenia, first onset psychosis, there has been evidence of tardive dyskinesia-like symptoms. So there is a theory that possibly that this could also be the neurobiology of schizophrenia as an illness and not necessarily only related to the antipsychotic drug treatment. Most patients are often unaware of these movements, and the DSM-5 diagnoses it as a medication-induced movement disorder that persists despite discontinuation or change of the medication. So the operational diagnostic criteria is usually one or more movements of moderate intensity or two or more movements of mild intensity after 3 or more months, or after 1 month if the patient is more than 60 years of antipsychotic treatment, or within 4 weeks of the discontinuation. So this could happen with medication treatment or with medication discontinuation. So these symptoms must persist for at least 1 month after discontinuation of the medication for it to meet the diagnostic criteria in DSM-5. So usually they are very serious and disfiguring, and usually most of the time are often permanent, but you'll notice that up to 50% may be reversible. And they usually have common manifestations such as the ocular muscles, where there is a consistent blinking or blepharospasms. In the neck, there will be persistent retrocollis or torticollis. There might be some facial spasms or tics, where you might notice a patient might either be lip smacking or trying to move their lips in a certain way, and grimaces. In the trunks, they might be shoulder shrugging, pelvis rotation, diaphragmatic jerks, or rocking or forced retroflexion. You could also have the masticatory muscles involved, where the patient is noted to be chewing, even not having anything in the mouth, and also lateral movements of the mouth and the tongue and the buccal muscles. There may also be evidence of consistent trunk protrusion, which is usually, as we said earlier, that the patient may be unaware of the movements, and they're usually objectively explained by their next of kin or people next to them. There also may be difficulties swallowing and abnormal sounds from the pharynx and palatal movements. So these symptoms, sometimes once noted, can be consciously suppressed, and usually they worsen with distraction. So a patient might tell you that whenever they are at home in a calm environment, the movements are much less. But whenever they are involved in activities of daily living, like work or maybe moving around, these symptoms are more. So thus, you will notice that even patients, when they are admitted, these symptoms may reduce, considering that in admission, they are less distracted than when they are in their home environment. It's also exacerbated by stress and anti-Parkinsonian agents, as explained previously, and they may disappear during sleep. So peripheral TD, which is a peripheral muscular use, such as the trunks, like shoulder shrugging and pelvis rotation and rocking, may be more comorbid with the acute movement disorders that we discussed earlier than the orofacial presentation of tardive dyskinesia. The pathophysiological theories are that there is a striatal dopaminergic and cholinergic imbalance, and then there's also upregulation, supersensitivity of postsynaptic dopamine D2 receptors in the basal ganglia, following chronic blockade from these medications. And then this imbalance leads to striatal disinhibition of the thalamocortical pathways and striatal GABA hypofunction, which now leads to enhanced dopamine transmission, leading to these symptoms. When you look at statistics, 15 to 30% of patients who are on chronic treatment for psychosis or schizophrenia, they may present with these symptoms, and actually up to 70% in the high-risk population. When you talk about high-risk populations, these are patients who are on high doses of antipsychotics, those who are inconsistent stopping and starting antipsychotics, that is intermittent treatment, those who are also on concomitant anticholinergic treatment, the elderly, especially people above 60 years old, 60 years of age, female gender, and people who have been known to have organic disorders such as dementia, epilepsy, or intellectual developmental disability. Also, people with a previous history of head injury, people with mood disorders, people who present primarily with negative symptoms of schizophrenia, people who are known to have chronic diabetes, and patients with evidence of prior drug-induced acute dystonic reactions. And usually up to 5% of patients per year on antipsychotic exposure develop tardive dyskinesia, while as I said earlier, up to 50% of cases are reversible. So apart from antipsychotics, there are also some known culprits, which we have said people on anticholinergic use, they might also have a risk towards developing acute tardive dyskinesia. Some antidepressants have actually been shown to also have the risk. Some antiemetics, such as metoclopramide, some antiepileptics, some antihistamines. Lithium has also been shown to have a risk towards tardive dyskinesia. Amphetamines and anti-Parkinsonian agents such as bromocriptine and levodopa, as we said, increase the risk of this tardive dyskinesia. When you are trying to manage these patients, first, if these symptoms of tardive dyskinesia present atypically, meaning that it's not so chronic use that has led to this, you might need to investigate and rule out the presence of primary physical illness as a determinant of this illness. Usually there is something called the abnormal involuntary movement scale, which is a 12-item scale that scales in all these parts of the orofacial, extremity, trunk, global judgment, and dental status. So each of the section is scored from 0 to 4, and it is a good idea to assess at baseline and within 3 months of management. So meaning once a patient presents to you with these symptoms, it's good to have a baseline so that over time you are able to document and notice whether there is worsening of symptoms or improvement of symptoms. And also because over time, in medicine, we are moving towards defense medicine. We might need to also have medical legal issues whenever it comes to such patients. So next, after that, you may also need to review your medication and the history and identify possible causative agents. You may also need to reduce the dose to a minimum effective dose. Withdrawal of the offending antipsychotic may initially worsen tardive dyskinesia, as we saw in our second patient. So it's also something you might need to educate their relatives on, so that when they see it coming, they don't think that you don't know what you're doing as a doctor. Also, temporarily raising the dose of the antipsychotic may give immediate relief, while you are trying to add a specific treatment that may be commenced. So at that point, once you have started the specific treatment, you can now reduce the antipsychotic dose. You also may need adjuvant agents. So tetrabenazine has been shown to be of benefit, but you might need to carefully stratify your patients because you may need to be aware of its depressogenic effect. So low-dose dopamine agonists have been used, but also be careful because there's the risk of reemergence of the psychotic symptoms that you're trying to treat. Benzodiazepines have also been used, but evidence base is poor, similarly to calcium channel blockers. Some people have also used anticonvulsants such as levetiracetam, and antioxidants are commonly used such as vitamin E, though the efficacy is not necessarily noted to be highly effective. Others that people have used include botulinum toxin, amino acids, ondansetron, melatonin, pyridoxine, and baclofen. And we are also moving towards more modernized treatments such as transcranial magnetic stimulation, but these I've only seen in literature. The American Academy of Neurologists has the 4 as their proven treatment options. Number 1 is prevention, where this means you try as much as possible to clearly demonstrate that this patient has a psychotic symptom or a psychotic illness before starting them on antipsychotics, so as to prevent the occurrence of these effects whenever you decide to put patients on antipsychotics. Secondly, valbenazine, which is a VMAT2 inhibitor, such as similarly to tetrabenazine. They also have approved the use of clonazepam and ginkgo biloba. So anticholinergics have been known to exacerbate the problems, so it's a good idea to reduce slowly and stop if possible. If residual symptoms are tolerable, wakeful watching is recommended because over time, tardive dyskinesia tends to improve with time. If severe residual symptoms and there is significant functional disability or it's life-threatening, consider changing to alternative antipsychotics, which have been shown to have less risk of causing this tardive dyskinesia. So this may include antipsychotics such as clozapine, followed by quetiapine, followed by olanzapine, and followed by risperidone. So finally, we might have to think about the elephant in the room, which is a difficult balance between the reduction in dyskinesia versus control of psychotic symptoms. So you don't want to completely stop the antipsychotic because there's risk of relapse of psychotic symptoms, while also you want to make the patient and the relatives as comfortable as possible by relieving these disturbing symptoms of dyskinesia. So as we said earlier, prevention is the best strategy. So stratify your patients, make sure they highly have an indication for antipsychotic use before you decide to start them antipsychotics, and also close monitoring for the presence of these tardive dyskinesia symptoms, and also clearly demonstrating them and writing them down if they're present or if they're absent. Prognosis is related to how soon the offending medication is discontinued or reduced, or how soon you are able to treat the tardive dyskinesia. So as you said, follow-up may need you monitoring residual symptoms, regularly review need for continued antipsychotic treatment. For example, if you are very clear about a psychotic illness that is secondary to the use of a substance, you may need to, at one point, think of, if it's the first onset, at one point you may need to taper down the antipsychotic, and also clearly record down these symptoms and management plan in your case notes. Finally, we will talk about the severest of them all, and the most life-threatening of them all, which is a neuroleptic malignant syndrome. Luckily, it is rare, which occurs in up to 0.5 to 1% of patients, and it is characterized by muscular rigidity, decreased consciousness, hypothermia, labile blood pressure, and increased creatine kinase. This evolves very rapidly, and it may last for longer periods of up to 14 days if untreated. It presents to 5 to 20% of patients on oral medication, and up to 30% of the patients who present with it on depot formulation. Those will die from the condition if untreated. In short, patients who present with neuroleptic malignant syndrome, it might be a good idea to have them in a facility where, if things go south, there is a presence of critical care treatment and ICU facilities. So the commonest cause of death in such patients is usually renal failure due to rhabdomyolysis. So as we say, this is a medical emergency. It's a good idea to have them in a facility that can handle emergencies. For these patients, you withdraw all antipsychotics immediately. Dantrolene may be used to reduce muscle spasms. Dopamine agonists such as bromocriptine may reverse antidopaminergic effects. And if it's necessary to use antipsychotics, use them after recovery. And then usually you may have to have a 2-week interval where you observe them. You also might need to treat symptomatic symptoms. So if there's a hypothermia, treat hypothermia. If there's a high blood pressure, manage it. If there's low blood pressure, manage it. If the level of consciousness is so low that you might need respiratory support, offer respiratory support. So those were the presentations for the day. I hope I have learned enough as you have. Thank you very much.
Thank you very much, Dr. Joseph Nyamiobo, for that elaborate presentation on Parkinson's disease management and extrapyramidal side effects. It is a learning experience definitely for you and us both, as you've taken us through this. In summary, you've talked about James Parkinson, a man of many hats, and the cognitive impairment that comes with Parkinson's disease. Before we go to the Q&A, these meetings do not happen in a vacuum. We do have partners and sponsors who help make this possible, and I would like us to give them a few minutes of our time so that they can be able to share with us a thing or two, and then we can move on to the Q&A. And I would be encouraging that we put them in the Q&A section, then we can go through them in a short while. In the meantime, Evelyn and Tim, please share, and the floor is yours. Welcome.
Thank you so much, Dr. Rajab, and also many thanks to Dr. Nyamiobo for the articulate presentation. Even us on the marketing side, we really learned a lot. Thank you for that. So allow me to share my presentation. Just one second. Okay, without taking much further time. So my name is Elvin Amugune, and I'm part of the Square Pharmaceuticals team. And we appreciate this chance to be able to get to partner together in a bid to add value, not only to partner in practice with you, but also just partner to make sure the healthcare space is always growing. So I'll start by giving a background of Square as a company, then Square Pharmaceuticals, so that you can get to understand what we are about. And thereafter, I'm going to showcase our brands. So Square Pharmaceuticals is the first multinational company from Bangladesh, and it has been leading the Bangladesh pharmaceuticals market since the year 1985. I know now we can say Square Pharmaceuticals has been leading in the millennial age. Like, I don't know if most of us were born at that time. Anyway, on a light note. So just a brief background on Square Pharmaceuticals. So before delving into the pharma, Square has dipped a foot in many different fields. I'd say 27 different companies in various fields, in healthcare, in textile, in FMCG, in IT, in media and entertainment, in agro processing, just to name a few. So Square is so big, and hence the need to be able to diversify and venture into other markets. So from the 1981 data, it was seen that in Square, in Bangladesh, the multinationals were dominating the brand production. And by this graphical depiction, you can see that all the brands available in Bangladesh in the year 1981, 75% came from the multinationals, and the locals only were contributing 25%. And hence there came a need to be able to grow their own brands. And now in 2023, you are able to see that the locals were able to grow to 92% of the local pharmaceutical manufacturing, and the 8% now came from multinationals. So we hope to get to this point in the Kenyan market also, where we reduce the dependence on imported goods and also make our own. And this will also impact The quality, because we are able to regulate them by ourselves, and also the affordability, being that Kenya is in the resource-limited areas of the world. Square Pharmaceuticals has been shown to have a market capitalization of $2 billion US. And this significant reach can only be achieved through trust of our brands, trust by the users of our brand, the end users who are the patients, trust by the prescribers of our brands, which are the healthcare providers like yourselves. And also, and this has been achieved through offering quality, efficacious pharmaceutical agents, as well as initiatives in the CSR and having that social responsibility to be able to impact the society, and also offering affordability, as again, in resource-limited situations where Kenya falls part in, adherence to medication is impacted by cost of medication. So quality, with Square, you're assured of quality and affordability. So now delving into the manufacturing sites, Square has 15 different manufacturing sites in Bangladesh, including an insulin unit. And many of these sites are approved by all the major worldwide regulatory bodies, that is the US FDA, UK MHRA, TGA from Australia, SAHRA from South Africa, and Visa from Brazil, and last but not least, BPB Kenya. So I'll just show some images of the units, the manufacturing units available in Bangladesh. So as you can see, we have the general production units. We have the penicillin unit as an independent unit, the natural medicine unit, all independent, the general solid dosage units, the cephalosporin unit, ophthalmic units, insulin unit. And this is important to note that all these units are built as per the US FDA and the EU requirements. And they all have such a capacity to supply millions of brands, millions of batches of brands to be able to, let's say, to be able to sustain an entire generation. So now that you've seen our background in all the different areas, in all the different fields that Square has a hand in, and also in the pharma space, now let's delve into Pharmaceuticals Kenya. And one thing that we like to pride ourselves is that Square has set up a local manufacturing plant, a state-of-the-art modern facility, which you're going to see just shortly. And we like to say the investment in Kenya is to serve the Africa. So we say Square Pharmaceuticals is in Kenya for Africa. So the site area that now Square stands in is an area of 17 acres at the EPZ, and it was an initial investment of 75 million USD. With now currently we have the oral solid dosage unit, and now the phase 2 we are seeing Square moving into the liquids and even the injectables in the near future. And why is this important? We've seen all the plants, all the independent plants available by Square Bangladesh. So now with setting up this plant to serve the African market in Kenya, we are able to have this technology transfer of US FDA, TGA, UK MHRA, and all those regulatory bodies. We are able to see the standards of practice are going to be different from what we are used to. And the aim again is to supply high quality, efficacious, affordable medicines in the whole of Africa. So I have
the profile of
that's just a brief video to see the inception of Square Pharmaceuticals EPZ plant. So I'll just play it for a minute.
And the profile of Kenya's pharmaceutical and manufacturing sector is set for a major boost following the installation of a plant in Athi River Town, Machakos County. Now, Bangladesh-based company Square Pharmaceuticals has built the factory on 6 acres of land at the export processing zone in Athi River. The total cost of building the plant is estimated at 8.4 billion shillings. Now, the facility, which will start production early next year, is expected to help minimize the country's dependency on imported pharmaceuticals and reduce the cost of drugs. Kenya will also receive technology and training to manufacture difficult-to-make medicines, such as anti-malarial, anti-psychotic, anti-diabetic, and antiretroviral drugs.
Yeah, So that was nationwide news showing the inception of Square EPZ plant, and that was in the year 2021. So we are proud to say we are already making those difficult to manufacture brands. And for the purpose of this presentation, even mentioning them now, our antipsychotic regimen is now officially coming from the Square EPZ plant. So this is the Square Pharmaceuticals EPZ reception, and this is at the board of a big hospital in Kenya, Mpisha Hospital. So visiting the plant and being able to see the quality of our brands, and now they can be able to tell with the bias of now stocking or having our brands, you can be able to see where the bias is coming from. So this is the first phase products of Square Pharmaceuticals manufactured in Kenya across all different regimens. We have the pain medication, the antifungals, antihypertensives, and as we've mentioned, the antipsychotics is at the bottom left. I'm sure for the most of us, we are going to recognize a brand we all know, a household name in practice, the Deprex 5 and Deprex 10, which you're going to talk about it shortly. So now this is the site 3D model of the Square EPZ plant. And this is how it currently looks like, the gate at the entrance. This is now the solid dosage, the general solid dosage unit that we have. This is how it looks like at the river. These are real photos of the plant, and even on the inside, adopting, as we've mentioned, state-of-the-art technology that is the biggest and most modern in East and Central Africa. As you can see, adopting epoxy panels, which are less prone to crevasses developing and less prone to having bacteria or microbes hiding in the crevasses, and also quite easy to clean. We also have state-of-the-art modern machinery that are controlled by computers to have less human interaction and hence less risk of contamination. As you can see, some of the machinery in the plant, a QC lab that makes sure each batch that leaves the plant meets required standard and pharmacopoeia rules. And now that you've learned about Square Pharmaceuticals, all the way from Bangladesh, now all the way to Kenya, and as we've said, in Kenya for Africa, we now delve into our brands, our portfolio. So our first brand targets a condition that has been described in the presentation, which is schizophrenia. And according to the WHO data, it is shown that approximately 1% of the global population develops schizophrenia during their lifetime. And not more than 20% of these patients are able to show recovery. And with that, we present our brand. We call it Deprex, which I believe is a household name. And if not in some institutions, we are hoping that it's going to be a household name going forward. This is our brand of olanzapine, 5 and 10 milligrams. And we say Deprex is the logical choice for schizophrenia, both positive and negative symptoms. Deprex is currently the brand leader in the olanzapine space, and we are proud to say that it's one of the first brands that came from our Square EPZ plant. So when you're looking to prescribe an olanzapine, I'd urge you to pass the benefit of our Deprex 5 mg and Deprex 10 mg tablets. Our next brand, also with Deprex, we say no more schizophrenia. Our next brand targets Parkinsonism, and not just that, the EPS symptoms that have been largely explained in our presentation today, induced by antipsychotic drugs. With that, Square introduces Parkinil, which is our brand of procyclidine, 5 milligrams tablet. And with Parkinil, we say we want to bring back the quality of life patients living with Parkinsonism. So Parkinil targets the EPS symptoms aside from the Parkinsonism syndrome, and which have been widely explained, like the dystonia, akathisia, Parkinsonism, tardive dyskinesia. And we say that our Parkinil is indicated to control troublesome mild EPS symptoms induced by neuroleptic drugs. Parkinil can also be used as an adjunctive treatment for all forms of Parkinsonian syndrome. Parkinil is also used for the symptomatic treatment of idiopathic, post-encephalitic, and sclerotic, Parkinsonian. And one important thing about Parkinil is the safety and tolerability it offers, where we see that Parkinil has a lower potential for abuse and symptoms of euphoria compared to benzoxol, and thus contributing to a better safety and tolerability profile in clinical use. So when you're looking to prescribe an anticholinergic, targeting the EPS symptoms and Parkinsonian syndrome, I'd urge you to pass the benefit of Parkinil to your patients. So just a summary of the brands, I'd say brands at a glance with a pictorial depiction of how they look like. This is our Deprex 5 mg, Deprex 10 mg, our olanzapine, and last but not least, our Parkinil prochyclidine. Thank you so much, and back to you, Chair.
Thank you very much, Ilvin, for this wonderful presentation, walking us through this journey of Square Pharma from Bangladesh and here in Kenya, and making us feel more connected to a company closer home. For those who just joined, welcome, or you joined a few minutes ago. In summary, today we've been talking about Parkinson disease management and extrapyramidal side effects. Dr. Nyamiobo has gracefully taken us through it, talked about James Parkinson's and the many hats he has worn over the years he practiced. He's talked about cognitive impairment in Parkinson's disease, the perceptual disturbances that come with it. Parkinson's being caused by multifactorial agents. There can be motor and non-motor symptoms, the psychotic symptoms that come with it, and the diagnosis of it being largely clinical, unless it's for studies or other uses. We've talked about extrapyramidal side effects, mostly with first and second generation antipsychotics, but there are some second generations that still do have this side effect, and the 4 forms of it have been mentioned. He has discouraged us from routinely prescribing anti-Parkinsonian medication together with antipsychotics. He has also talked about the neuroleptic-induced tardive dyskinesia, which is mostly with chronic antipsychotic use, and it affects 15 to 30% of patients. We've discussed treatment strategies. You start with investigations, consider lowering your dosage, adjusting it, or changing to something else that is less, that has less side effects of the extrapyramidal side effects. He's also talked about the American Academy of Neurologists and the 4 strategies they have. He's mentioned the elephant in the room to treat schizophrenia and to also counter the side effects with anticholinergics. We've talked about the medical emergency being the neuroleptic malignant syndrome, very rare, but can be fatal if ignored. So it is good to have a watchful eye and be able to pick it in good time and treat. Then our sponsors for the day, Square Pharma, have gracefully taken us through their products, their company, and how close home they are. So now we go to the Q&A, and I see there's already 3 questions here. The first one, I think, was, okay, how can we differentiate essential tremors from Parkinson's disease? I'll read them all and then I'll leave it to Dr. Nyamiobo to tackle them. Kindly, okay, that one, CPD points, we'll discuss it at the end. I have seen one of the indications for Parkinil is oral facial tardive dyskinesia. From presentation, we learned anticholinergics worsen the tardive dyskinesia. Please clarify. Thank you. Dr. Joseph?
Okay, thank you very much. These are interesting questions. So when we talk about essential tremors, from my understanding of the essential tremors versus Parkinson's, essential tremors are primarily cerebellar issue problems. So they'll present with these tremors that are mostly at rest and also probably an ataxic gait. While in Parkinson's disease, we also have, it's primarily a basal ganglia problem with the substantia nigra. So there will be also presence of the clear motor manifestations of bradykinesia with also this gait that is not ataxic, but almost like a shuffling gait. Also, you might notice that in presentation, in Parkinson's disease, the prevalence increases over time, while in essential tremor, it's known that there is a bimodal age. Usually there is an early onset and a late onset essential tremor. Usually with essential tremors, due to it being a cerebellar problem, some people will also say that whenever the person takes alcohol, it seems to calm down those tremors. And also the treatment mostly is with beta blockers compared to Parkinson's disease, which is primarily a dopamine agonist treatment. I hope I have answered adequately. And to the second question, so I have seen one of the indications of Parkinson is orofacial tardive dyskinesia. So yeah, it is known that these anticholinergics may worsen tardive dyskinesia, but when it comes to the orofacial presentation, usually it is known that the orofacial one presents with the acute dystonic symptoms, as we talked earlier. So the role of Parkinson or procyclidine is to treat the acute dystonic symptoms, as you now also look for something else to treat the tardive dyskinesia symptoms. Unlike when it is the presentation that has those muscles of the trunk and the neck, at that point, usually presentation is rarely with acute dystonic symptoms. So role of anticholinergics is a bit lower compared to in the orofacial one. Thanks.
Thank you, Dr. Nyamiobo. Maybe a question for me is, do these anticholinergic agents also have benefit in other motor disorders like tics on its own?
I've not seen them being used in tics, essentially, considering some of these tics may not necessarily be dopamine problems, but I might need to just need to research more and read more about it before I can answer with confidence. That I might say I don't know much about.
Thank you for that. I honestly have to give it up to you. The background of this webinar is actually, it was first done as a physical talk by a senior colleague, Dr. Max Okonji, who has had years of experience with all these. And when we tasked Dr. Nyamiobo with this, he gracefully took it up and he has done justice to this topic, despite having started with a disclaimer of having little to no experience with Parkinson's. And I believe that we have all learned. There's one more question before maybe we finish. We don't intend to keep us here too long. May I know the relationship between cravings, anxiety, and GABA synthesis? From Eric Oyo.
Wow. So this regards GABA. Today's topic was, I think we might be digressing a bit. I might not have read enough about this, but we know that GABA is an inhibitory neurotransmitter, and usually helps with the calming movement. While craving and anxiety, I wouldn't know much how it's related to the GABA.
So Eric, maybe we will take that up, and once we are ready, we can actually be able to come up with a talk that is relevant to these concerns at some point in the future. Okay, one question here for our sponsors. It's not clear the effective dose for procyclidine. Ilvin, maybe you could just advise what is recommended, the dosing, if I may just say Parkinil then. Have we lost her?
Yes, I'm here.
Okay.
Initial dosage is 2.5 milligrams. Currently, our brand is 5 milligrams. and it's 2.5 milligrams 2 to 3 times a day. But now you can step up to 5 milligrams depending on the symptoms of the patient. So it is largely customizable. But for the initial dose is 2.5 mg.
Thank you. And I think also to remember that as it was shared in the presentation, it has better safety for dependence or the lack of it compared to what we have had in the market for a long time. So what we are being sensitized on is that procyclidine is safer than the alternative that has been there. I think we have hit more than the 1 hour mark. It would be unfair to keep us any longer. It is an evening and we have other things to do. This wouldn't happen without you, the attendees. At the height of it, there was over 240 of us here for our beginning of the year. This is very encouraging, and I would encourage us to keep that momentum even as we continue. I also would like to take this opportunity to thank my friend, Dr. Joseph Nyamiobo, for gracefully taking up this task and doing justice to it. For those of you who are friends with Dr. Okonji, tell him that justice was done to this presentation. To our sponsors, Square Pharma, we thank you for actually taking this up at the very early stages of the year when most companies are still planning. You are there to step in and be our partners with the first webinar and hopefully not the last for the year. We intend that if the heavens permit, every second Thursday of the month we will have a CME and there will be reminders to it. So let's hope that it will be a learning journey so that by the end of the year we have all benefited for our benefit and also for that of our patients and the community at large. CPD points, at present it's mostly registered, those who are registered by KMPDC. We are trying to have on board the other boards, like the psychologists and also the one for the clinical officers, so that they can also benefit by attending. And for doctors, that means that by early registration, it automatically uploads to your ICPD portal. So do not expect to be sent a token in your mail. For as long as you're here and you did register, when you do check your ICPD portal, is that the points will automatically be there. I hope that is satisfactory. I sincerely thank you for your time and wish you a lovely evening. Thank you very much. I see a hand from Susan. I don't know if we can. Okay, it was raised and then taken down. Okay. And again, the president was here earlier. We had her remarks and yeah, there's good things coming. So let's just be here and be part of the process. Thank you so much. With no further business, I would like to adjourn the meeting. Have a blessed evening, everyone.
Thank you.